My name's Tania and I'm a shared care educator based in Sheffield, and I currently run the Yorkshire and Humber Shared Haemodialysis Care course. And for those that you don't know what the course is about, I'm going to explain a little bit about that in a few minutes. But the aim of the course is to train staff to encourage, to train and to support patients in their own care. So I hope that we can engage you this afternoon in what we've got planned for you. There's a bit of an interactive session in a little while following the presentations that we've got for you initially. So I'm going to make a start by talking about the Shared Haemodialysis Care course. So it's called Developing Training for Patients and Staff, Experiencing What Really Works. So I hope that we can give you some guidance if you're thinking of running your own course or even running some of the sessions from it, so you can take something away from it in order to be able to train your staff. Okay. Originally, when we had the grant from the Health Foundation, it was all about asking for projects to look at changing relationships. So that's what the course was funded with, some of the money that we had from there. It's in its 4th year now, and we've trained over 300 members of staff. We've trained mainly nurses and support workers, but we have trained the one doctor, which we're quite proud of. Hopefully in the future we'll be training more doctors. It started in Yorkshire and Humber a couple of years ago, 4 years ago, sorry, and for the first couple of years it was just Yorkshire and Humber, but for the past 2 years it's been mainly staff from the other regions. And just to mention here that we're not the only trainers. We are aware that there's a couple of other training courses that are in-house, but we are the only course that has been training delegates from the national regions. Before I go any further, I'd really like to just make some acknowledgements as to who has helped us and supported us in the course. Initially, both matrons Melinda Howard, who's with us today, and Christine Stubbs, for their fantastic design of the 3-day course and their vision for the future of the course, which we all were a little bit dubious about initially, I have to say, because it was all very new to us, the way in which it was developed, but it's proven to be a very successful programme, so thank you. The 6 main units I'd like to thank in Yorkshire and Humber for their engagement and participation and their support all the way today. Our patient partner Andy Henwood, who's been with us from the very beginning, and Liz Hill-Smith from the Berkshire consultancy firm, who was employed by the Health Foundation to support us when we started running the course, because they externally evaluated it for us and gave us a lot of useful feedback. We've got an awful lot of very valued patient partners that have been with us from the very beginning and are constantly helping us to present. So I'd like to thank those very much. And obviously the doctors, the senior nurses and the psychologists for their participation in the course. They've been present since the very beginning and have given their time and their presentations very freely, and they continue to do so. Obviously the project team, we're very fortunate in our team. We work very hard, all of us together. There's been an awful lot of effort put in, but I think that's because we're all very passionate about shared care. We all very much believe in it, and we all feel that it's very much the right thing to do, and that shows in the way that we work together as a team. And finally, for B. Braun, for their conference centre, Martin mentioned them this morning, but we have Jane Doherty, who's been a constant support to us and very, very helpful. And that's made a huge difference to delegates when they come to the course, because it's such a beautiful centre and it enables us to have breakout sessions and for it to be in a very nice, welcoming and familiar surroundings. So thank you to everybody. So coming now to what we do on the course and why we think it works. This is just a course outline really, and it's just a list of the subject areas that we cover within the course. But throughout the course it's very much interactive, and what we reinforce throughout all of these sessions is that shared care is very much an individualised approach to care. It's about participation at any level. It's about being patient-led, most importantly. So giving patients the choice and the flexibility and the time to do it as and when they want to do it, which I think is the most important factor, and I think that's what we've heard today. That's what makes it work. If we tell people what to do, they don't want to do it. We have to guide them towards doing things for themselves, and they've got to do what motivates them to do shared care, and that's very different for a lot of other people. For some people it might be time to get on a bit quicker. For others it might just be because they want to do what everybody else is doing. It's whatever motivates them that we're teaching. So to bring out some of the key components about what we think makes, why we think it works, it's a very interactive experience and a sharing of experiences. And Hero talked about that this morning, about learning, and that's the most important way to learn, really, about sharing experiences with other people. There is time between the nurses learning and then putting it into practice. So we spread out our 3 days over a period of about 6 weeks. So nurses learn the theory and the foundation of shared care on day 1. They go away, they start to practice a little bit, they introduce it to patients, they have those all-important conversations with them, and then they come back and they share that with us. And that's what I think really works. They share it, we build on that, and then they go away again, and then they come back again. So it's a bit-by-bit approach. It's a very realistic course. We don't talk about pie in the sky. We know there's no extra money for shared care. We know there's no extra time. So we try and make it a very realistic problem-solving approach, things that can be applied in your own areas. So nurses have the time and space to really think about the quality of experience our haemodialysis patients receive. And it's lovely for nurses to take that time out, not to be doing mandatory training, not to be learning how to do UKM results or whatever. It's about thinking really about what difference does it make to what difference can we make to our dialysis patients, to the quality of care they receive. And it is about caring. By empowering patients, that is about caring. So it's teaching that there is a different way of caring at the moment. And Hero talked about that this morning. It's a change of culture. Empowering patients is about caring them. It's not necessarily about doing things for them. And whilst they're on the course, they experience a variety of teaching and learning techniques. It's not just PowerPoint. We have facilitative sessions, we have exercises. There's all sorts going on in the course. And all of those exercises, all of those techniques, the nurses can then go away back into their own areas and use those techniques with patients. So there's an experience of quite a wide variety of teaching. And throughout the course, there's building blocks that come together and make up the full picture. These are some of the comments that we've gathered over time from what the nurses have said about it. And some of the nurses are saying there's no more Groundhog Day anymore. And that means to them that it's not a routine system anymore. They're not just ploughing patients through the system, moving them through in a very routine way. It's about listening and responding and caring for people more than just their physical needs. And I really like this one. I've learnt some valuable things about myself as well as patient needs, because I think if you understand how you as a person learns, how you as a person feel about things, then you can you're far more likely to be able to empathise with your patients. So, if I was to give you an ideal recipe for shared care, from our experience and learning, it's shown us that shared care really works and produces a near-perfect cake, if you like, if you've got the following things. So, we've talked about that this morning very much, that you need very engaged managers. It's no good all of your nurses on the ground floor learning how to do shared care if your managers aren't engaged with that. And we've been very fortunate in our areas. We have a chief nurse here with us today who's from Sheffield, and she's been very engaged in that and has supported us all the way. You need very enthusiastic drivers, and you'll see from Andy and Matt's presentations in a few minutes, and certainly from the ones that we've heard this morning from Cannock and from Leeds, that it's really important that you have somebody that's a really strong driver working in your own areas to drive shared care forwards. Obviously, you need the training of enthusiastic staff, and that includes your support workers. We need to include everybody in this. And on the course, we don't know who the support workers are, to be quite honest. We don't know who the ward managers are when they come on the course. Everybody's in the same boat. We're all learning the same principles. You need support and encouragement, and coming to a network like this is giving us support and encouragement. I often say to the nurses on the course, please come along to the network meetings, come along to the learning events. It's lovely for new staff to be coming along to learn about things, but it's really important for you, if you've been on the course and you're doing shared care, to come back and reconnect with people, because it's that networking that really helps support you and keeps it going. And obviously the patient champions are really, really important. I'm going to go away today and look at how we can engage our patients even more than we are doing back in the units, because it's the patients that are influencing each other really. Okay, so where has this course led? Well, from their observations and their participation in the course that Yorkshire and Humber have run, Nottingham have adapted the Yorkshire and Humber model and are running their own 2-day course, and Andy's going to talk about that in a few minutes. Matthew Gales from Bristol has just completed his own first 3-day course, and so we're now kind of getting to the stage where instead of just training the trainer, we're training the trainers for the trainers. So we hope that that will continue, and we hope that if anybody else wants to run the course in their particular areas, that between us all we can support you too and spread the word even further. Leeds, as you know, they've spoken this morning, and they've moved shared care into paediatrics, and that's a huge move really and very influential. And if you can just imagine what working with children can do in shared care, and how that can influence us as when we're working with adults. We all know what our transitional patients are like and how difficult they are to move into the adult world. If they're already doing shared care as children, imagine the difference, you know, how different they're going to be when they move into the adult services. It can only help them. And we've now produced really a lovely network of renal carers and renal patients with a shared power and purpose. So we feel quite proud of what we've been able to do, and it's lovely to be able to share that with people and to move it even further on. So what I'm going to do now is introduce you to Andrew Corbett, who's working in Nottingham, and he's going to describe his 2-day course to you.
Thank you. My name's Andy Corbett. I'm the shared care lead at Nottingham University Hospital. We observed the Yorkshire and Humber course about 2.5 years ago, and really from there have used their resources to develop our course. When we started looking at it, the big challenge we had was actually trying to get a number of staff onto the course for 3 days. Managers felt that we wouldn't be able to free up that amount of time with our workload. So we decided to develop our own 2-day course, focusing on local barriers and solutions and the challenges that we've had. It's still very much based around the Yorkshire and Humber one. We don't have there's a couple of the subjects that we've dropped out of the course that we thought we didn't need it at a local level. But the important for us was actually getting staff educated. For anything to succeed for us, we tried to roll out buttonholing, and it rolled out too quickly, and we got a lot of problems. So we learned from that, actually, we need to get people educated, an idea of what's involved. And for us, the most important part of the 2 days, there are 2 points. One is the patient representative and their view. Is not only the change that it makes them on dialysis, but the change it makes to them outside in the real world as well. The second is the micro-teaching. Most of our Band 3s hate it, but we relate it to renal subjects. They can pick whatever they want, and they just do a 5-minute presentation. And for that, it's really key, because it shows how much you can put into 5 minutes to actually teach patients about whatever topic it is. And we've taken that approach. We're trying to maintain that everything's bite-sized. So it's not a big training session of a machine of how to line it. We break it down into the arterial lines or the venous line, and we just take our time. very important for us that actually we involved patients right from the start. We had about 7 or 8 patients who were involved with setting up the course. We had the usual nurses, doctors, clinical psychologist, and at the time our matron involved as well. So we've had a lot of support. Name of our program, SID, came from a patient, share your dialysis. We certainly found out what they did and didn't want. There's been strong links related to that self-care is a good driver for home dialysis, but the patients were very vocal that this was not to be used as an incentive for patients to go home. And that was really because as soon as the consultants found out that they were interested in going home, involved with the care, they suggested going home. And actually that was a big barrier for them that they wouldn't have got involved at all. So it's run as a very separate program to a home program at the moment. But I do see that in the next couple of years there will be a natural joining of this. Design and layout of packages. My previous role, I was home dialysis training for 9 years. We had trained over 90 patients. We got a program of 35 at home and gained an awful lot of information from there that we've used into the SID. And the important bit is little chunks. And we've devised 9 packages that are just 2 or 3 sheets with some competencies that they can work through. Because a number of the home patients said the amount of information they get for problem solving and how to do things, they said if you'd given me all that paper on day 1, that would have put me off. So it's always been about listening to what the patients want. And I say, really, our patient was, he's been in renal for 30 years, he'd been through all modalities, and he was reluctant to talk in the first course. But now can't wait to actually be involved because he can see the benefit that the staff get out of it. At the end of the 2 days, we always have a light bulb moment, and I would think 90 to 95% is that talk on the first day by the patient of how empowering being involved with the care can be. Just an idea of the packages that we've developed, and it does cover all aspects of dialysis. So our progress so far, we've got 4 satellite units as well as the main unit. We've been running the course every 2 to 3 months over the last couple of years, and we've managed to get well over 30 of our staff through. And we are certainly finding that the more staff we've had through from certain units, their success is developing the shared care. We've got our Centenary unit and King's Mill, which are further ahead than the main unit, which has been a different challenge. We've got over 40 patients involved in shared care currently, out of a total of 340, but there are others who are doing things that we need to catch and get signed off. And how do we measure a success? We just ask 2 simple questions for the patients. 1, would you after being involved with SID, would you continue to be involved? Either yes or no. And probably the more important one for us is, would you recommend it to other patients? And a very simple yes or no. We're trying to send out 10 every couple of months, random to patients who are involved with the program to get their feedback, and they can add other comments as they wish. But again, as has been said, the biggest driver for the whole program for us is education of staff and B, other patients and encouraging other patients. Thank you.
Thank you very much. So my name is Matthew Gales. I'm a staff nurse and I'm playing out being a shared care educator. So I work in the North Bristol NHS Trust. So a little bit about me. I started dialysis over in Bath, where we first were asked if we'd like to maybe ask patients if they would be interested in getting involved in their care. And from that point forward, our approach to shared care has been very, very grassroots. For a start, we didn't call it shared care when we started out, we called it self-care. And within about a few months of us introducing it to patients at Bath, I moved to a different job. And we set up a self-care area at a different part of Bristol. And the idea behind this was a bit of a pilot to try and, again, educate some patients in their own care, bring them forward with the aim that they would dialyse themselves completely and independently. And that was about 2.5 years ago, 2 years ago. And we were invited to come up here to the second shared care learning event by chance, really. And we realised, actually, we shouldn't be restricting this to just a certain number of people who want to do everything. We should be involving all of our patients. It should be a universal choice. And why aren't we doing that? So from that learning event, we were invited to come up to the shared care course up in Sheffield, and we began slowly sending staff to that course. So this is a picture of one of those courses. I'm on there somewhere, and we eventually sent over how long? About a year, maybe 17 staff from our 6 satellite dialysis, well, 5 satellites and 1 main unit. But that really only amounted to 1 or 2 staff per unit, and we soon realised, actually, we weren't getting the results that we wanted. Our audit, our census results were showing improvements. We got up to 25% of our patients doing 5 tasks or more, but it was variable depending on the unit, and there was obviously other reasons for that. But on the whole, results varied. And we kind of thought, people aren't coming to Sheffield. We're getting certain units that aren't sending staff all the way up here because of the distant travel, because of family reasons. And so we thought, actually, do you know what we need? There's a lot of problems getting staff out of units, full stop. We need a local course, and that would possibly solve our problems. So I was asked if I'd like to assist on the Sheffield course. Tania basically coached me during over 2 courses, brought me on, gave me a lot of educational input, and that was really useful because I'd never taught to a group of people before, never stood in front of a group of people like yourselves and taught before. So it was all very new and very different, and that's a big, big challenge, especially when you're trying to create something a little bit different. So following that, like Tania said, about teaching in a different way, lots of group activities. We've done some of that today. That's an example of one of them over there, isn't it? The networking. The shared care course is different. It's not just all about PowerPoints. And we really wanted to train as many people, and I put on there 25% of staff, but I'd like at least 25% of staff trained, because the more staff who are trained, the more word gets out there about shared care. So about a month ago, not even that really, we rolled out our first course. And that's some pictures from our first course. And this is basically a little bit about how we did it and how we made it local. Obviously, Andrew's made it local to Nottingham. We have our own local challenges. We've kept the format a little bit similar to how they've done things in Sheffield, just for simplicity. And I imagine as experience goes on, we'll trim things according to what we need them to be. But prime things we needed to think about was using homegrown talent, because people are not going to always be there to support us when we needed it. So we have our own patients who were willing to come and talk. Julie's covering her face there. It comes back to what Andrew was saying, and what a lot of you have said today. It comes back to the patient. Your experiences are invaluable, and when we look at our evaluations for our course, nearly everybody who came on our course said the same thing. That interaction with that patient, Julie, telling us about her story, explaining what it meant to her to get involved in her own care, was a catalyst. It was a change in them. They felt like they really, really needed to do something with it. So that patient is vital to any course if you're planning to set it up yourself. Staff, it's not easy to do it on your own. You've got to think about all the logistics of everything, and having other people involved is important. So we started bringing on board our doctors. Our doctors have been in touch with the doctors up in Sheffield. They've got the information. We were kindly given a lot of slides, posters, handbooks, everything, all the information relevant to carry through a shared care course were given to us, and our doctors went with it, and as its picture shows, her giving that talk on the medical side, the research, the literature. So yeah, we downloaded all the research, and we're given all the research and all of the paperwork from the website, the shared care website, and I've printed that, adjusted it slightly, put our own labels, our own brands on it, referring obviously back to Sheffield, but it's all the same. It's pretty simple if we don't reinvent the wheel. So top tips. Give yourself lots and lots and lots and lots of time. We found that we tried to put the course into place in March, April, and I just couldn't get the rooms. Couldn't book any of the rooms that we needed for the course. There was lots of regular meetings that were going on that you just couldn't fit anything in. In the end, the rooms we had weren't ideal. Our second course has already been booked, and I've got massive rooms, so we've got lots of room for those group activities that are important. Again, it comes back to network. That was a bit of foresight there, wasn't it? Use the talent that you've got. Find out. Tania came down and helped us teach on our course. Networking again. Resources. What is essential and what is desirable? It doesn't take a lot to actually run a course physically. The rooms are important, but that was the only monetary cost, really. Tania came on the goodness of her heart. My time was my own. It was part of my own working time. And I arranged it so I could be off the unit to teach. So somebody had to cover me for that. My biggest point, coming back to it, is avoid PowerPoint at all costs. Nobody wants death by PowerPoint. We've all been in training where we've just been sat there staring into space, waiting for the training to finish. A lot of those group activities are vital to get important points across. And again, coming back to the evaluations of the staff, a lot of the staff said the most important things they learned was during those group activities. Only the first day of the course had a lot of PowerPoint in it. And that's the stuff you can't get away from, the actual literature, the research, the important bits. So, I've done what I didn't think I would do and just talked without looking at my notes. Like I said, we've got a second course booked in October. That'll be completely on our own. We won't have Tania coming down, perhaps. Big sad first there. We'll plan to have another course in December and January. And we want to roll it out regularly because it's really important to flood your units with as many staff as you possibly can, as quickly as you can, to really go with that enthusiasm. Our shared care has now been added to our pre-dialysis education. We've changed the way we actually teach our pre-dialysis patients, and it's very, very group-orientated with practical learning sessions now, instead of just death by PowerPoint. We're going to have a bi-monthly working group, networking, in order to try and sustain that change, because that's something we talked about here last year at the learning event. We need sustainability. It needs to continue, because patients get transplanted, people come off shared care, and people lose enthusiasm. So we're going to have a working group every other month, hopefully, with patients and nurses to try and keep the enthusiasm going. And hopefully, with more nurses being trained, we'll really drive shared care in our trust. Thank you very much.
Thank you very much, Matt and Andy, for that. During the time that we've been working together, we've all generated ideas, actually, and certainly we've come away with ideas in which we can improve our own course. So it's been lovely, actually, networking with them and moving things forward together. So can I bring along Melinda now, introduce you to Melinda Howard, and she's going to take you through the next part of the session.
Hi. Okay, so this session is going to be about barriers and solutions, and it's going to be interactive. So I know you just had lunch, and you want to sit down and relax. I'm really sorry, you're not. So before we begin, I'll just give you a little bit about why we're doing this, really. All of us experience change in our lives, either in a professional way or in our home lives. And we know that change can be really uncomfortable, and none of us like it. And the idea of change, if we were to say change at work, it tends to bring kind of negative thoughts and feelings, if we're honest, really. And certainly speaking to some of you during the breaks, some of you said that when things are mentioned at work about making changes, it can feel a bit uncomfortable. And if we had time and I was able to go around the tables and asked you about things that you've actually wanted to change or introduce, you might have some barriers of why you perhaps didn't, I don't know, go to the gym or, go on a diet. And, I think that's what people can do sometimes, have certain barriers. So the purpose of this session that we're going to introduce now is about how you can bring about change in your clinical practice. And in this case, it's shared care. So what we're going to do is that this is the session that actually takes place when Tania is running the shared care course. And it's quite a valuable session, really, because people get to really explore some of the barriers and also, more importantly, the solutions that go along with that can make a big difference to how you can introduce not just shared care, but actually any other clinical practice or any other sort of area that you want to introduce. So how we're going to run this session is, I need to check, how many tables do we have? Rebecca, how many tables do we have? 14. Okay. 12 tables. Okay. So how we're going to do this is tables 1 to 6. I'd like you to focus on barriers and solutions affecting patients undertaking shared care. And so tables 7 to 12, if you can focus on barriers and solutions affecting staff implementing shared care. And what we'll then do is, if you spend about 10 to 15 minutes on that, we will then spend, We will then spend some time evaluating, sort of analyzing the feedback. What's going around right now is they're giving out some flip chart papers that's actually being drawn already for you to highlight barriers and solutions, which are really important, really. And you've got pens to make notes. Okay, sorry to break it up, but we're going to have to start to do the feedback. I know there were some really good conversations taking place, so I'm really sorry. Oh, heated conversations. Okay, so, sorry, Martin? You're not having a heated conversation. Okay, so let's start with the group, the tables that were, the people that were looking at patient barriers of undertaking shared care. Who would like to go first to talk about your top one issue?
Okay, well, I'm going to say there's two things here. I know we can't.
Okay.
You said one, but two. Poor communication was a big barrier, and fear was another barrier for patients.
Okay.
And on the solution side, we said education and peer support.
So you feel that the education and the peer support would help with the communication?
That's right, yeah.
Okay.
And overcome the fear that many patients express.
And how would you do that? How have you said that you'd overcome the fear?
Through
Education and training.
At the right time.
At the right time.
So having education and training at the right time will help to reduce some of the fear.
Yeah, and reiterating it on a regular basis, so re-evaluating it and ensuring that the same message is getting through consistently so that no misunderstandings can occur in the meantime. So accepting that it's not a one-off education, it's an education, it's a process that carries on over time and needs to be renewed because more people will be coming into the programme and more people will be moving out of the programme.
Okay. Can you all hear that? Yep. Does anybody want to add anything to that about that improving communication and trying to dispel fear are two really important things to engaging patients into shared care? Has anybody had an experience of what's been discussed at this table? Sorry.
On our table, we've got some of us from the satellite and two of the girls from the main site. And the fear and staff barriers is a big thing in the main site. And we've been saying train all the staff, a lot more staff need training, and then do make some the champions of shared care and a lot of some patient advocacies, really.
Okay.
To help other patients. Peer support.
So the peer support of actually training staff to kind of help with the communication issues and the fear,
and like
work alongside.
But not just one champion. Like obviously the main site, they've got a lot of patients to come.
Okay.
So, a few champions really.
And do any of you have any sort of champions for shared care in your areas? Nobody? That's interesting, actually. Is it something that you would consider going back?
Yeah.
Yeah?
Yeah.
Okay. So it seems that actually it goes hand in hand, those two things. Okay. So if we just focus at the moment and further sort of barriers that might prevent patients from engaging in shared care, is anybody else that would like to share the sort of top one barrier that, for those of you that have been looking at it?
Yeah, Melinda.
Oh, okay. Yes.
Right, we've got one which is based on sort of the extra time it takes. From a patient's perspective, looking at maybe being seen as a burden or a hindrance in relation to both staff and patients that follow, perhaps. And we were looking, that's inevitable. It's something which you're going to be explaining to people that does happen. But with training and as their confidence grows in relation to what they are doing, they will get naturally quicker. And therefore that hindrance, that will sort of really turn then into empowerment and a greater understanding and a better quality of their dialysis.
So just to stop you, so you're talking about hindrance, so you're talking about the time.
The time,
because
yeah.
obviously it takes time to train patients.
Yeah, indeed.
And that time means that they have to have time given to them, so it slows things down.
Well, yeah, and I think from my point of view, for example, when I'm sat on an afternoon shift and I know my time is going to take longer, whoever's coming on twilight,
Okay.
they may well be coming on later. That's the
Okay.
hindrance bit. But I think that's soon overgrown, and we've got, I think, providing there's a positive attitude from the centre itself in relation to the encouragement of individuals to do it, and clearly within that is you're not a burden, it's not a hindrance, it will get quicker. The peer-to-peer bit, which is clearly a very big thing in relation to other people saying, yes, I started like that, but I'm now here. And then that continued encouragement.
So we've got, again, that the peer support and the peer sort of pressure as well, because it's a double-edged sword, isn't it?
Yeah.
That you feel the pressure of patients waiting, but on the other hand, by undertaking shared care, you're being a good role model, and in the long term, actually, it won't take as long.
Yeah.
So there's a short-term gain for long-term gain, isn't there? Okay, right.
Okay.
Thank you. Oh, sorry, Martin. Let's get the mic over.
Hi, yeah, we're lucky to have two patients joining us in our table. Anyway, what we have identified, one of the barriers that we have identified and as suggested by the two is the language barrier. And the solutions that we have come up was the family support, peer support, staff support, and translators.
Okay. Yeah. Are those things readily available?
Yes, hopefully. But in our unit, based on my experience, we easily get support from family members, from the peers from our peers that who can speak the language of the patient, and we can easily get translators during clinic visits.
Okay. What's the experience of the rest of you, where you may have patients that have got language difficulties or there's barriers?
I think one of Shyla went on our shared care course, and she came back with a DVD, and we've actually used that on a patient, and that's been quite helpful. And then some extra visual aids. The handbook's very good, but to have some extra visual things in for the people, because we've got some that don't speak English at all, and maybe the literacy that can't read or write. So it's just adapting it really to a lot more visual.
Okay. When I was actually fortunate enough to go to Jönköping, the renal unit in Sweden that started the shared care project with Dr. Paul Leboy, I don't know where he is, another consultant and a charge nurse. And there was a Vietnamese patient there that had gone on holiday and had ended up on dialysis. And obviously the nurses didn't speak Vietnamese, and the Vietnamese patient didn't speak Swedish, so they had to interact. And I'm not sure of the story, but he ended up actually being on dialysis there for a long time. And so what they did was that they actually produced pictures of how to undertake dialysis step by step. And so when we looked around the unit, he actually showed us the book of how he actually taught himself, with some support of the nurses, obviously speaking a little bit of English, using this kind of pictorial book. And it was actually a really good idea. And it's one that we've brought back, but obviously not had to use in York. So it's just something to consider, actually, that, it's not just about using language. You can actually use, as you've said, visual aids as well. Okay. Oh, somebody down there.
Hello.
Hello.
We've come up with the similar one on time.
Okay.
This is fundamentally the way the units are run. So, for example, your 7 o'clock patients on for 3.5, coming off at 10:30. Then between 10:30 and 11:30, the machine has again got to be washed, the beds are to be washed, relayed, etc. And so we think this mechanistic kind of approach that operates currently from one patient to the next doesn't provide the time for shared care. And the solution may be to target certain individuals such that they may arrive that little bit earlier, while the machine that's been left from the first session can be used and lined up with the patient for the second one, which may run from 9 o'clock through till 1 o'clock. At the moment, that seems part of a barrier as far as the staff are concerned in finding the time to give the tuition to the willing patient.
Okay, thank you for that. Would any of you else like to comment? Because I know from Tania running the course, and certainly when I ran it in the very beginning, the issue of time came out regularly, that the lack of time. So do any of you have any kind of solutions of how you found your way around the fact that time is very precious? Yes, indeed. Oh, the microphone's coming.
We do try and focus, as we do through our 2-day course, of actually breaking down into 5-minute sessions.
Okay.
There's a lot of things that we do with the machines and with patients that are part of the job that you can actually, if you're resetting an alarm, just explain what's going on. I think there's actually a lot we can do without actually having to add a great deal of time into the day to make it impossible to develop shared care.
So what you're saying is that when you're really busy, short staff, you've got sickness, what you do is that when you're putting a patient on, you can actually go through some of the things like blood flow, or if they're on heparin, and go through little things like that, is what you're saying?
Yeah.
Okay. And somebody mentioned, certainly not in this group, but in the previous group, about doing things like turning the machine to face the patient so they can actually see the dialysis machine. So they're aware of, how long they're on and, what their UF rate is. It is all about taking small steps, isn't it? I think I saw a hand. Yeah.
I think in our unit, what we do is, like for patient, we've got a lot of self-care patient within the main unit. What we tend to do is we tend to allocate machines to patients who are 4 hours, who put themselves on, and those who need beds and things like that. So the self-care patients, when they come in, they go straight onto their own machine, line their machine, which is quite, for us, I think it's less time consuming because they don't have to wait, because they come in, do their own things. But like sometimes if transport is delayed for them, what we tend to do for them is line the machine, and then when they come in, set up everything, and they put themselves on. I think allocating machines for self-care patients who are well knowledgeable and put themselves on, we do that for them, which I think has worked very, very well for us within our unit. Okay. I think that's another way of looking at time allocation.
Okay, thank you. Are there any other patient barriers that, I know I'm aware that there's been tables at the back that haven't actually spoken. Is there anything that you want to add in terms of staff or patient barriers now, for things that actually you feel are quite important to share with the group? Because actually most of the things I'm sure that you'll be thinking about, they'll be sort of represented, in the other groups there. Anybody want to share anything? Okay.
Just one other one we came up with was that it's really important to have the engagement of medical staff and nurse leaders. So we only got in the beginning of our solutions, but one of those we felt was really important, which I think has been exemplified today, is hearing patient stories. So people feeling very much, in particular that our patient representatives here, that the people at more senior levels, so medical staff and nurse leaders, need to talk to patients directly to hear their experiences and the benefits of this type of approach. We thought there were potentials. We started to look at of could there be an information day run by patients for, but you'd have to get those staff there along to that. But also looking into opportunities of things like videos and patient stories on videos being taken to meetings if that was the only way that we could get the views across.
Okay.
So that was just some thoughts so far.
So you talked about sort of exposing or asking senior staff to come and talk. So how would you do that? How do you get your matron, your senior nurse, your lead clinician, how do you get them involved? Cake. Cake. Okay. Right. Okay. Anything else apart from cake? Yeah, cake will work. Yeah. What did you say, Tania? Tania was just saying that it's worth probably asking Hilary Chapman, who's the chief nurse, if how she got involved in shared care.
So, hello everybody, it's a real pleasure to be here. I'm the chief nurse from Sheffield Teaching Hospitals and I've been involved in the programme from the outset. And I think that's one of the key things is get your senior team involved from the outset, get them engaged, get them interested, and the patient power is huge. So get them to talk to, listen to patients, listen to staff, get involved in the programme and take the feelings of threat away from the staff who might not like the concept, because some of us are frightened of change, as you said earlier. So that's, I think, worked well for us. You made me. Now, yeah, so just to say I was invited from the very beginning, and I think being involved from the beginning was actually very powerful.
As a patient on dialysis, you are a bit of a guinea pig. The amount of nurses that are being trained at university and other aspects that come along and sit and talk to you. I think one of the good ways of doing it is to get the patient to invite somebody to come along and see them. They don't necessarily need to come on a specific date, but during a specific time. But I also include in that the chief of the hospital. I include in that the chief admin staff, the people that are swinging things around staff resources and all those sorts of things should come along, not just the nursing staff. But the ideal opportunity is to get the patients, either as an individual or as a group, to invite them to come down, let them know, look, I'm there 12 hours a week, you could come down anytime you want, and we'll have a quick chat and a cup of coffee and a slice of toast. But not a cake, because we don't do that.
That's great. Can I ask a question of Hilary, if that's all right? It's Martin here. So what was it like when our patient partner came to the trust board? Can you just tell us a little bit about that,
I'll stand
please?
up so you can see who I am as well. Yeah, we invited the shared care team to our trust board because we have the medical director and myself have a slot on the trust board every month for what we call clinical update, and it reminds our board that we're not just here to manage the finances, we are a service and we are providing services to patients. So the patient voice at the board is the thing that I think swung the thing for the whole board. It's very powerful, and I would also say that Andy's suggestion of if a patient emailed me or got in touch with my PA and said, come and meet me, I think it'd be really difficult to refuse that. We have 2,000 patients in our organisation. I'm yet to refuse an invitation from a patient or a member of staff as well. So some of our support workers have invited me to go and work with them in renal. If you remember that, Tania, a long time ago. It's a really powerful thing to do. But I always say to teams who are coming to present at the board, bring a patient with you. It tells the story from a completely different perspective, as we've been learning from our tables today. The patients are the expert, very powerful, and it really swung it for us, and we nearly always encourage people to try and bring a patient with them now. Yeah.
Thank you very much. There you have it. So get your chief nurse, get your chief exec into your units, talk about shared care, spread the word, invite them, get your patients involved to actually invite them as well. And I would echo that because certainly the chief exec in our hospital has often said, if you invite me, we'll come down, and we have invited him. I'm aware that there's some tables that haven't spoken. Do you want to talk about your top sort of barrier for patient to staff? Yes? Oh, we need a mic. that one, sorry. Right. It's the York table. And Oxford, I think.
Hi, I'm Maggie from York. We've got 2 people from Oxford on our table, but the rest of us are York people. We went through quite a lot of things that they've already been covered. One of the things that Oxford brought in were that they have really good staffing levels, which is like, I think, how do they do that? But and that's not a barrier in itself. But what's a barrier is the mix of patients. They get some very acutely ill and sick patients, right? And it's kind of making sure that we keep the momentum for the chronic patients who are there, who need that focus as well. So talked about maybe having a champion on each shift who can really be focused on their care while the staff who are looking after the sick patients can prioritise those. Is there anything you want to add to that? Sorry, I'm not sure if I... Yeah. Oh, yeah.
Yes, apart from this is just to link back to the time management issue, where especially now satellite units, patients do prefer hospital transport, even those who are independent, so they wouldn't necessarily need it, but then that would stop them to come in to the unit at such time they could be trained to do different elements of the shared care for themselves. So that is a barrier from that point of view in our unit.
So you're saying it's a barrier for the patients requiring hospital transport to bring them in, because obviously that will affect, and there's a delay.
Talking about, which I do think there's a very good idea, what the other unit uses a 6:30 start time, and then you have an hour to sort of train someone to have a one-to-one with the patient. But that is not possible where all your patients are coming in an ambulance, where the ambulance staff starts at 8 o'clock, so the earliest they would be in at 8:30, and that would be, I think, very hard to persuade people to give up the very free hospital transport and make their own way on their own expense sometimes.
So sorry, what's your solution around that then? If you're tied into the hospital transport, and obviously you'll have less time.
I just identify this as a barrier, and I don't want to say that take it away from them. It's just it is a barrier, because otherwise the time is not there to.
So if we open that up then to the rest of you, so there's a problem that they obviously want to give more time, but they can't because they're tied into the hospital transport that brings them in much later. I don't know if anybody else experiences that, where you've got issues. Yes, you're nodding. So do you want to share some of the solutions or some of the ideas you currently do? Well, what they're saying is they're tied in, so there's a problem there. Okay. And okay.
We have experience with transport problem. There's always a problem with us, actually. But we inform our patients that if in case they're going to be late to come, we just do the other bits, that we line the machines, we prepare the bits, but they open their packs, they put on their needles, and they still feel that they're part of the game.
So that's a good compromise, that actually they can't do all of it, but they can do some of it, so you can keep the motivation. Because the main thing is to keep them motivated, really. And that would apply, you know, for anybody learning anything and being involved. Okay, which table hasn't? Right. Yes, of course. Hold on. Use this mic.
A lot of satellite units, certainly those at York, use a taxi as a matter of course. I mean, York has the main renal unit, has the main transport problems and issues which we're trying to sort. But outside of that, if you're going to put a program in where it starts half an hour earlier and the hospital won't provide the taxi, then the transport, then one of the options might be look at a taxi. You're using less transport in relation to hospital, but it'll make sure the patient still gets the best outcome.
Sorry, we've got time just for one more, really quickly, because we've got the next speaker here. Do you want to say?
One thing from a motivational point of view that we've been looking at is we're doing patient newsletters. So within that, there's a shared care element with what we're going to do. And last November, we did a a patient information evening, and then we're doing something else this year called a summer social to not make it quite so informational. But with that, teaching blood pressures and stuff, and having family members there as well to get involved with and encouragement. So it's just an idea.
Really sorry, but we're going to have to just sum it up now. So while you've been talking, Tania's been busily typing away. Yes, great. Okay. So just to feedback, this is what you've all said in terms of the barriers, but some of the solutions really. So you mentioned about poor communication and about how we can kind of make that. And there were some really good ideas about that the education and training is key really to actually do that. And that also helps in with the fear that actually the more that you give people information and give them training, you can help to dispel that. But it's got to be continuous, as was mentioned. Patient champion and nurse champions came up regularly throughout. So that's quite clear, really, that if you want to drive things forward, you have to have people in your clinical area helping you drive that as a driver. Time, well, we all know that. It's very time precious in the NHS. And it doesn't matter whether it's shared care or anything. That's going to be a big issue. But, as somebody said, you can do it in small steps. So it doesn't have to be that you have to teach them everything. And if they do come in late, you can actually line the machines and they can actually get the trolleys ready and put the needles in. So they're still engaging in shared care. I think the encouragement and reassurance is obviously without say. About being able to allocate machines so it's kind of smooth flowing and you've got the area prepared. The senior staff engagement is vital because you have to have buy-in, and that's picked up on the courses really, that you get nurses come along who are hugely motivated and they go back to the clinical area and there's no one to help them drive this forward. So the advice is invite those key people to your areas, get them involved and invite them on a regular basis. Don't just do it once because they can, lose sight because there's so many challenges working in the NHS. We talked about language, possibility is a barrier, but you all came up with the solutions, really, of having DVDs and visual aids. And I think that was it, really. This will probably go onto the website, along with the other sort of information, so feel free to go back and have a look. And thank you to Tania and the other speakers. Thank you.